The Iowa City Foreign Relations Council hosts community programs to address topics of international interest. We thank our members, volunteers, and interns for making these forums possible since the year that Tokyo Disneyland opened in 1983. So that's your trivia for today. I want to acknowledge our university and community sponsors and supporters, the University of Iowa's international programs, the University of Iowa's honors program, the University of Iowa Center for Public Policy, and the Stanley U of I Foundation Support Organization for their financial support. And I thank today's special sponsors, Christopher Squire, Conrad Schultz, and Mason K. Braverman. I also thank City Channel 4 in the back here for professionally recording our programs for telecast on City Channel 4. Yes, we have a wave back there. Yes, thank you. So you can see it on City Channel 4 or 18-2. And also the U of I Library's digital archives, where you can watch all of our past programs, which includes over 220 ICFRC podcasts that now can be found on iTunes. So please look for those too. Now it is my pleasure to introduce Edith Parker. Dr. Edith Parker serves as the Dean of the University of Iowa College of Public Health. She also directs the Prevention Research Center for Rural Health, based in the College of Public Health. She formerly served as Departmental Executive Officer of the University of Iowa Department of Community and Behavioral Health. Dr. Parker holds a bachelor's degree from Davidson College, as well as a Master's of Public Health and Doctor of Public Health degrees from the University of North Carolina in Chapel Hill. She served on the faculty of the School of Public Health at the University of Michigan before joining the University of Iowa in 2010. Please join me in welcoming Dr. Edith Parker.
Thank you so much. It's an honor to be here today, and I think it's very appropriate for me to be speaking to a group with such an interest in international affairs, because I'm one of those folks who found public health when they went out of the country to work in Africa, and when there's not a public health system, then you quickly find out what public health is. And I think the other thing is that with the globalization in the world today, public health really is global health. As we all know, it just takes one person on an airplane, and we have Ebola here in the United States, but also sort of the implications of globalization and trade impact us all in terms of air quality and other issues. So okay, oops, a little bit too far there. So what I want to do today are a couple of things. One is really to talk a little bit about one of my favorite subjects, the College of Public Health, and what we're doing in global health activities. And then the second is to talk just a hot topic for me about a recent trip and collaboration that I've been involved in with some Indian partners around really trying to influence environmental health research in India by introducing and trying to increase the use of community-based participatory research. So what is public health? Public health is the science and art of protecting and improving the health of communities through education, promotion of healthy lifestyles, and research for disease and injury prevention. This is a quote from C. Everett Koop, who was the Surgeon General of the United States. Healthcare is vital to all of us some of the time, but public health is vital to us all of the time. And there have been some estimations from Robert Wood Johnson Foundation that actually healthcare is probably responsible for about 10% of generating health. That really what generates health are things such as social determinants of health. Do we have good housing? Do we have good nutrition? Are we safe from violence? Are we able to exercise in our communities? And so that really is the importance of public health in sort of preventing disease. So our mission at the College of Public Health is to promote health and prevent injury and illness through commitment to education and training, excellence in research, innovation in policy development, and devotion to public health practice. Our vision is to serve Iowa and the Midwest as one of the nation's premier state-assisted schools of public health and lead the global community in rural public health education and training, research, and practice. We have expertise in our faculty that is applied often to issues of importance in Iowa, but those same faculty are applying those skill sets to issues of importance in other countries. So we have went through a process probably about 5 years ago to identify what we felt like are our collective areas of excellence. And those are community engagement, both for engagement in research methodology, which we'll talk about in a few minutes, but also engagement in terms of taking our results and making sure that we're informing communities of those results and working with them around interventions, policies to address those health issues of concern to those communities. The second is rural health. It's hard to be in Iowa and not know something or be focused on rural health. So that is one area of excellence that our faculty have. And the third is an area called comparative effectiveness research, which is essentially trying to, be it a drug, be it a public health intervention, to make sure that you're not just comparing that to no intervention or no drug, but that you're trying to take what is the best possible intervention and then test a new intervention or drug to that. And we have quite a lot of expertise. We have one of the foremost clinical trial research networks here. We also have a lot of expertise in our Department of Epidemiology on clinical trials, and then throughout the other departments on testing interventions around rural safety and health, obesity prevention, reduction, all kinds of topics. So who are we? Well, we have 78 primary faculty, 62 secondary faculty, and 85 adjunct faculty. These are figures from this past fall. We had 450 degree program students enrolled. 288 of those were graduate, and 162 are from our undergraduate, which is a new program we're very pleased and happy with. It's in its third year, so we haven't yet graduated a class, but we're building it up. And back to my point of discovering public health, long after I'd done my undergrad, one of the things I'm most excited about is that there really is a lot of interest in new programs springing up in undergraduate in public health. It's designed so folks can go ahead and perhaps pursue an advanced degree in public health, perhaps pursue an advanced degree in medicine, or perhaps do nothing in the healthcare field, but they will be a very good citizen and advocate for public health, we hope. And then finally, 205 staff. Many of those are research staff. One of the things we're proud of is we say the expression we hit above our weight, the boxing, in the sense that we are one of the most productive units on campus in terms of our research and externally funded peer-reviewed research. So in FY 2018, we had $43.8 million in external research funding, which averages out to about $572,000 of research expenditures per capita for faculty. And we have an average of our funding our salary of about 59% offset. Now, money is not everything, and the point I want to drive on this is that these are all research that are very impactful for things at our local, national, and international level. And I think we have an excellent reputation when I'm traveling around, and perhaps even before I came to Iowa, for our research in public health and in the health sciences and biomedical research. So I want to talk now, and I'll point at the person who's really helped us a lot, Sophie Switzer, who's our global health coordinator. And probably about 5 or 6 years ago, our then dean, Sue Curry, who's now our interim provost, really was interested in, I think, was hearing a lot from faculty that we really wanted to do more investment in global public health. And so we hired Sophie, which was the best thing to do. If I'm seeing nods of people who've worked with her. But if you really want to be successful as a dean or a chair, then you hire good staff and then you get out of their way. And so Sophie has done a phenomenal job for us. And we really have been wanting to increase the engagement and communication within the college. As you can imagine, in any unit, there are people doing global health that we didn't even know were involved in those aspects, people with interest in it, people with past activities. We also were really interested in establishing student programs abroad so that our students would have those experiences, and we'll talk about some of the successes in that. And then to introduce ourselves to the rest of the campus. I think some folks knew that we were doing global health, but it would be, oh yeah, I know that one person or I know the other, but to sort of introduce what we were trying to do in our collective presence. This year we're looking at increasing our global curriculum and global content in the classroom. We really want every student, whether they say they have an interest in global health or not, to be exposed to it. Ideally, I would send every one of our students outside of the country for a global health experience. We're not there yet, but I'll keep. And I think the impact of that, I think it's 4 students, I think on the slide I've got, who went last year of the number we sent on overseas experiences through funding that we had at the school through a generous donor. And 4 of the ones we sent had never been out of the country, had never had a passport. One of them was talking about the impact and actually came to tears, said that it not only had impacted her, but it also that when her sister heard she was going to go overseas to Romania and then maybe go to Ireland to see some of their long-lost family, she got a passport and met her over there. And then the mother said, hey, wait a minute, maybe not this year, but how about next? So I think that impact of traveling outside of your environment, in this case, this was a student who'd only been on an airplane once before, and as she admitted, it was only from Madison to Chicago, so maybe that didn't count. And then in the future, we really want to increase our faculty engagement with institutional partners outside of the United States and also increase our global research opportunities. So what have we done? We've had student opportunities abroad, and we've joined HACODAPEC, which is a long-standing program. I'm sure some of you who are probably involved with Rotary know about that. We had not participated in that and have done so the last 2 years. And for us, we really are trying to have a variety of programs. I think previous to our hiring Sophie and thinking more thoughtfully about global health experiences for students, we would have folks such as ex-Peace Corps volunteers who would say, just give me the money and get out of my way. I'm experienced, I know how to do this, I've got a site. And we thought we want to make sure that we have experiences for folks who've never been out of the country, who have never even thought about it. And HACODAPEC is just excellent because it's a shorter term, a lot of preparation. Students enroll in the class throughout the semester, study about Mexico, study about different issues they'll be working on. And it also is a chance for interdisciplinary because there are folks from pharmacy, there are folks from the liberal arts who are involved. So it's a great opportunity. We also have a injury and violence training course with our partners in Romania, and that's another thing. It's a week long, so students who have not maybe have a little bit nervous about having an overseas experience can participate in that. And then we've also set up a partnership with a group called Child Family Health International. That has is part of a WHO, has a lot of World Health Organization, has a lot of good experiences, so that's another option, as well as a program from NIH funded of research internships for folks who want to do research instead of practice, and then always there's an option of independent or faculty projects. Now, we've also tried to bring in folks through international visiting scholars. Some of them are people based in the United States who may be working for NGOs like Save the Children or John Snow International. Others may be, we have hosted visitors from India, a partnership we're trying to start with a university in Bangalore. We're also trying to look, as I said, at our course content. And we've also introduced a global health case competition that's open to everyone across the campus. I think last year we had students from 6 schools? 7. who work together on teams on a case competition that's focused on a global health issue. And we have one coming up this year's next week, I believe.
Wednesday, you're all welcome to attend.
Yes. And then also our student organization, we're trying to do more volunteer organizations and realizing, again, the globalization. We have faculty doing a lot with immigrant health now and trying to make sure that there are better birth outcomes for some of our immigrant populations. So that's another opportunity for our students in terms of volunteering to work on those projects. For our faculty, we really are trying to increase our international collaborations and partnerships. As I mentioned, we're also bringing global colleagues to Iowa. We're sponsoring research in different countries, a sort of pilot seed grants, trying to also work with them, the faculty who may be interested in introducing more global curriculum, and also have set up a faculty development grant for folks to get seed funding for research in different countries. Here, I mentioned the HCODAPEC as some of our coursework. Another one that is going on that's been pretty successful is a global health equity course where we use technology. We're using Zoom, and we've got students and faculties from institutions all around the world. They said next to the hardest time is figuring out when they'd have their live sessions because it's everyone from Beirut to British Columbia. But also they said everybody's on a different system. So every time we try to have a check-in, then it'd be spring break or some break in some university. So they said there were actually 2 or 3 weeks when they could find that everybody was in session at the same time. But the thought of this is that at each of the site, students and faculty will work on issues of health equity using a methodology called photo voice, where the populations they're working with will go out with cameras, document their life experiences, the health inequities that they're experiencing, and then come back and then use those as discussion points, but also to talk about projects such as talking to policymakers in their own environment about these issues and what needs to change. So we're very excited. It's testing it, but I think it's, for all of the students at the site, has given them an opportunity to learn more about all of the health equity issues around the world. And then we're also doing partnerships. I mentioned Child Family Health. We've had a long-standing partnership in Romania with the Cluj School of Public Health. We have new partnerships in Kenya and in Australia, and then in India, which we're trying to set up. And I think if we can get the MOU through the Indian institution and then the U.S. institution, and no offense to lawyers, I got 2 in my family, but sometimes it can be hard. But we think that this should come very soon. Some of the outcomes. So students abroad increased from 3 a year to 13 a year in this past one. We approved travel grants for travel to 7 countries. And as I mentioned, 4 of the 13 students left the U.S. for the first time. So this year, as of February, we're on track for 12 to 14 students to study abroad and have approved travel grants for additional to travel to 9 countries. And I just want to say one of the things we're very cognizant of is that we want to do this right. So our tenets are that we students approach every opportunity as a learning experience. This is not U.S. going in to fix cultures, that we want to be cognizant of ethical practices within the cultural context, that all students who want to go abroad should have the opportunity to do so. It should not be financial issues or others, time constraints. So that's why we want to have a variety of 1 week to a longer time period, and also funds to support that. And then we also want to encourage a complete holistic experiences. So, avoid the fly-in, fly-out mentality. So even though some of ours are a week, the great thing about HCODAPEC is the student is immersed in studying about that. So even if they're only over at the site for a week, that they've done a lot of intensive thought and reflection before and after they get there. So I wanted to give some shout outs to some of our current faculty who are doing global health research. The top is Rima Fifi, who is interim head of our community and behavioral health, whose expertise is in CBPR, community-based participatory research, mental health, and refugee health, and does a lot of work in the Middle East and North Africa. Rima actually came to us a couple of years ago from the American University in Beirut, but is a graduate of Iowa and finished her undergrad and her high school here many years ago. Wei Bao is a professor in epidemiology, has expertise in chronic disease and obesity and metabolic disease, and has got quite a few partnerships going in China now. Kelly Baker is an assistant professor in occupational environmental health and has expertise in water and sanitation and has active projects in India and Africa. And I should say all of these are involving students also. Corey Peek-Asa, who is our Associate Dean for Research and is a professor of occupational and environmental health, has expertise in injury prevention and has projects in Eastern Europe, Africa, and India. Some of those are capacity building with universities there on the areas of traumatic brain injuries as well as violence prevention. And then also in India, one that is focused on gender-based violence. Christine Peterson is an expert in infectious diseases and is in our epidemiology department and has research projects in Brazil and India. And she is actually does quite a lot with leishmaniasis, which is a disease, infectious disease throughout the world. And then Will Story is assistant professor in community and behavioral health and is an expert in maternal and child health. And so he has projects in India, Kenya, and a former project in Bangladesh. And he is actually heading up the project in India that Corey is involved with around gender-based violence and trying to, which, is a huge issue everywhere in the world, but is trying to look at how to change male norms of masculinity and see how much that might impact and perhaps reduce gender-based violence. And then finally, Diane Rollman, who is also the chair of our Global Health Committee and an associate professor in occupational and environmental health, has expertise in environmental exposures, particularly pesticides, and has a project in Egypt where she's looking at the impacts, particularly cognitive impacts, on adolescents who serve as applicators of pesticides in the fields. And that one also has a component to enhance the capacity of our Egyptian colleagues she's working with in terms of research methodology. So now I'm going to talk a little bit about an example that I've had just recently of a partnership we're starting up with some Indian colleagues. And it was a workshop held about a month ago in Delhi called Advancing Environmental Health Research and Translation in India through Community-Based Participatory Research Methodology. So let me give some background here because you think, wow, that's a weird topic. One of the areas of expertise in our college, and certainly personally for me and my research, has been community-based participatory research. So what is that? It's a partnership approach to research that fully involves community members, organizational representatives, and researchers in all aspects of the research process. So if you think about it, traditionally in public health and other areas of research, the researcher has come up with an idea, some research questions, designed a study, maybe went out to the community and collected data, sometimes maybe, but rarely shared what that results were, usually takes it back into the office, publishes publications, gets tenure, gets promoted, maybe becomes a dean, who knows. But all of that sometimes without the value of a community. So there's been a push to do more of this, of involving the people who are actually going to be the beneficiaries of your research in the research process. So some of the key principles of that is that it's collaboratory, participatory in all phases. I've been involved in research projects before where we actually, the topic of the research, in this case, asthma asthma in children in Detroit, particularly looking at environmental causes. That topic was identified by our community partners who were concerned about the high levels of asthma and also had made the link, perhaps before some of our researchers had, to environment. This was in the early to mid-90s, environment and its role in asthma. It also balances research and action, and that's important as we'll talk about this workshop, and the fact that it's not research for research's sake, that you're working with partners to either come out with an intervention, a program that may improve health, or oftentimes a policy, which is certainly in the case of environmental health, since one community cannot necessarily control their air quality or water quality, then we have to have policy change. It should be empowering. It should give power to community members to decide what the research is and where it will focus. And I think also for the researchers to be able to see their research really have an impact. Co-learning, and I think this was very much in our workshop, that researchers should learn from community members and community members should learn from researchers. In some of the work I've done before, we've had some interesting discussions with community members who asked, rightfully, how come you academics always have to be listed first on an article? And then we explained tenure, and they were like, whoa, go ahead, list yourself all you want. So, it's sort of that sort of thing. And I think for us, we learned quite a lot about realities of what people may face, in this case, in Detroit or other places. Should always be appropriate and beneficial to the community. And it should also focus not just on weaknesses. I think lots of time in public health research, we're focused on the disease and not thinking about all of the strengths of the community that we perhaps can build a solution upon. And so it really is balancing both of those. So why CBPR? I talked about oftentimes we've had historical exclusion of communities from influence in what could be called paternalistic research. There's a term, helicopter research, where the researcher helicopters in, does the research, and helicopters out, and no one actually benefits from it. I think there's questions of relevance of much of our research, direct benefit from some of it, and even sometimes hard. All I have to say is Tuskegee. And folks know, and I said it in India, and everybody nodded. I mean, everyone knows about that. Actually, that's not pedagogically. I shouldn't say everyone knows, and then ask, does anybody not know? That's kind of not good teaching. But anyway, it was when the Public Health Service wanted to find out more about the trajectory of syphilis, and so had a group of African-American men who had syphilis and didn't treat them, just did an observational study until finally someone came forward and said it was going on and it was stopped. But another thing is that interventions that we developed oftentimes lack community input and are not tailored to the concerns and are oftentimes not effective. Similarly, there's big concern with NIH now that it's about 17 years from a discovery of, say, a clinical procedure or a drug or even a public health program before it gets into practice. So perhaps involving community members while you're developing it or organizations would help with that. So the thought is that CBPR allows for participation of these stakeholders, which may better identify causative factors of disease, improve interventions and result in action, and also increase the rigor. A lot of our work is developing questionnaires, and so the wording, having community partners who can help. An example we had in our work in Detroit was we were very interested in smoking because that is linked to asthma, and the question came up from our partners, are you interested in marijuana? And we said, well, do people smoke enough that it would, and they said some, but after a discussion, they said, you shouldn't ask that unless it's absolutely necessary because people aren't going to answer the rest of your questionnaire. So you've got to make some some cost-benefit analysis of whether it's worth asking. And then I came across this quote a few years ago, and I thought it said exactly why we should do more engaged research. And this was a AIDS researcher who actually died on the Malaysian airline flight that was shot down over Ukraine. There were several folks who were heading from Amsterdam to Malaysia for the World AIDS Conference. So this is a obituary from the economist that said, instead of closeting themselves away in laboratories, he insisted that researchers like him should talk to the people whom their work was intended to benefit. He recognized what medical researchers often miss, that patients, even those participating in experiments, are not subjects, but partners. So in the U.S., we have a lot of CBPR, a lot of emphasis now on engaged methods and patient participation from NIH. A lot of those, as I said, were done, are kind of what's precipitating that is that there's a lot of concerns with that traditional research has either not been effective or sometimes harmful. And certainly there's a continuum of participation from, having maybe an advisory board, maybe asking focus groups to find out what folks think about a questionnaire, all the way up to CBPR, which is a little bit more, is much more participatory if done effectively, in that you're asking and working with community members to identify their problems to then focus the research on that. And what we found is that the history of CBPR in the U.S. was very similar to that of India. In fact, when my colleague at the Participatory Research Institute of Asia was somebody that I had read his articles for years. And so when we were able to work together, we found that a lot of the traditions and reasons for CBPR in India were similar to the U.S. But the one difference was that in India, folks don't seem to be using the participatory methods much for environmental health. So why environmental health in India? One is, and we'll talk, our funder, National Institute for Environmental Health Sciences, who was sort of instituted, or was the instigator, that seems a little bit more negative, but was the one who suggested that we do this, felt like CBPR would be very effective in environmental health because they've been funding it in the U.S. for many years, and they feel like that the issues around environmental health, particularly for marginalized populations, are such that if you don't do it in a participatory way, you may not find out all the nuances that are affecting it. But if you think about our environment in NIEHS, National Institute for Environmental Health Sciences, takes a really broad view. It's everything from what we think pesticides, synthetic materials. The built environment is big now. Weather extremes have come on, with the disasters as we're seeing right now in the western part of the state. And there certainly will be environmental impacts of that for mold and other aspects of that. Nutrition. E-waste is a big one, particularly for lower and middle income countries where we send all of our electronic waste. Combustion byproducts from factories. Personal care products is another big issue. I've sat through one of the presentations in India of a researcher at University of California, Berkeley, who's actually working with teens on and getting them to analyze their makeup, and the chemicals in there are frightening. And then medicines that we have, a lot of concern that perhaps some of the medicines that are in the water now are influencing as endocrine disruptors, or the hormones that are getting into the water when people flush pills down, and polluted water. So in terms of the global environmental burden of disease, 23% of all global deaths are linked to the environment, which is roughly 12.6 million deaths a year. 8.2 million deaths are caused by the environment or due to non-communicable diseases, most of which are attributable to air pollution. So the more we find out about air pollution, which we thought about respiratory, is also, I have a slide I think about that, huge issue now in cardiovascular health. Environmental risk factors contribute to more than 100 disease and injury types, and healthier environments could prevent the deaths of 1.7 million children under the age of 5 each year. So what are the environmental issues in India? Certainly, I think some of you may know that they have some of the highest pollution levels in the world. We were there in end of February, which was the good time. Colleagues had been there in November and talked about going the first time, not bringing an air respirator mask, which we brought. We ended up not using them. And she said that she developed a respiratory infection. This is a colleague from NIEHS that took several weeks and some antibiotics to overcome. And if you think about our air quality index, where 100 is around moderate, and then it goes up to around 500. I did take a peek before I came over, and 500 is, not safe for any living thing or way beyond not safe. And some of the readings in Delhi today were at the 500 level. So huge issue, I think, probably with Beijing right there. And a lot of it is probably, they think, due to mobile sources of cars, which is, in some sense, it's there's developed much more of a middle class, but with middle class comes the abilities to buy cars, et cetera. So that is one of their biggest issues. The other is climate change, which is increasing potential for heat waves and flooding, similar that we're seeing in this country, and certainly the same there. Toxic chemicals in the food and water supply, some of their sort of where we're different are things such as the e-waste that's contributed to that, and also they still do quite a lot of mining, and there's some pollution byproducts of that without less regulations than perhaps we'd have in the state. So a lot of issues that are going on there. And if this is a slide just on air pollution, diseases with the highest preventable burden. And I'm sorry that it's a little bit hard to see there, but 52 million in terms of lower respiratory infections. And these are all dailies with disabilities adjusted years lost. And so that combines the effects of disability as well as mortality. So you think about then there are 52 million lives, either of disability or mortality a year, just from respiratory infections. 26 million lives lost from neonatal conditions related to air pollution. 49 million related to cancers that are related directly to air pollution. 119 million that are related to cardiovascular diseases. 32 million that are related to chronic obstructive pulmonary disease, and 11 million to asthma. So air pollution is huge in terms of its impact on health and disability. Now, to address these, and this is NIEHS's schema, certainly takes a combination of not only physical environmental researchers and exposure research and toxicology and epidemiology, but also education and training, communication and engagement with those communities, and then understanding social determinants of health. Because, it's easy to sort of suggest that people are in control of their health, but when you realize that there are things such as housing and exposures to pollutants from housing, or where you live in a neighborhood, or being close to a factory, then those become the social determinants of health. So our rationale for this partnership was that we at U of I had expertise in community-based participatory health research and environmental health, and in using CBPR in environmental health. As I said, it was initiated by National Institute of Environmental Health Sciences. It feels like their portfolio of research that has used CBPR on environmental health has, as they say, really resulted in action, be it community interventions, be it policies. One of the examples that we talked about there was one from University of Southern California, who have researchers out there that do quite a lot on air quality. I would say that most of what we know about children and asthma probably comes from there. They have a long-standing children's health study from 1995. And in that example, they were working with their partners, mostly on mobile sources of air pollution, such as cars. And their partners said, well, that's one thing, but we're more worried about the ports. It's a big, huge port in LA and in Long Beach. And so the investigators started looking into that and found that the crude oil that's burned from these big tankers is much worse than what are coming out of other sources of mobile cars, trucks, etc. And that also the fact that nowadays it's much cheaper to put goods on a boat that goes from China to LA than put it on a truck that goes across the country, probably right down 80 as we're speaking, and then goes to the East Coast and then onto another ship that goes to Europe. So all along the way, there's exposures of either diesel particulate from trucks or from trains, etc. So in this case, when the investigators started looking into what the community members said, realized that this was a very potent source. And then they were able, using their resource and working with their partners who could advocate very strongly for this, to get changes in the Long Beach port so that now whenever a ship comes in, they actually have to plug into an electronic source and cut off their diesel engines, which will result in a lot less exposure. So those are the kind of things that community-based participatory research can bring to this. So we were able to get funding from NIEHS, but also from the Indo-US Science and Technology Forum, wrote a grant. And that's exactly what they want to do, is try to increase collaboration between the US and India. So our goals really were to work together to describe and reflect upon the CBPR methods used in the two countries. We wanted to do some co-learning, highlight the use and benefits of CBPR methodology in environmental health research, because as I said, India has used CBPR for many years, but not in environmental health. Showcase different approaches of participatory research, evolve an environmental health framework that focused on CBPR and would be relevant for India. And finally, and probably most importantly, I think, was really to look and identify collaborative opportunities for U.S. and Indian investigators to work together in environmental health in India and to use CBPR as the approach. So we had 35 participants for 3 days, and they included U.S. researchers. We had folks from Berkeley, Tufts, University of Southern California, and University of Oregon, and University of Iowa, and then also Indian researchers throughout the country, as well as some of the funders, realizing that funders would need to be supportive of this if Indian investigators were going to be able to get funds for this. Heavy emphasis on planning for future collaborations. And we focused on 3 issues in particular: air pollution, and these were all identified by our Indian colleagues of priority to them. So air pollution, pesticides exposure, and then disasters and environmental health consequences. And I should say that just in terms of next steps, we've had several calls just in the last since I've gotten back, one at 9:30 the other night, which challenges me because I'm usually in bed by 9:30. But we have to be culturally competent and also very participatory, because our partners in India pointed out that they were the ones who were having to stay awake till 9:30 while we were calling at 8 in the morning. So we're trying to shake it up a little bit and have some plans. I'm working with our colleagues at Participatory Research in Asia to both try to spur on research with folks that identified mutual interest. We had several pesticide researchers in India and the U.S. who would like to work together, as well as also to try to find a way to do more capacity building around CBPR itself in India. So I'm going to stop and take any questions, but thank you.
In terms of local environmental health issues, are any of your CBPR researchers investigating the public health effects of CAFOs, confined animal farm, CAFOs? Yeah, thank you. Feeding operations. It has it here. Yeah. So that's the question. Thanks.
Sure. Yes, we have actually in our Occupational Environmental Health Center, funded by National Institute for Environmental Health Sciences, Peter Thorne, who is director of that center, and many of the folks in there. One is Dave Osterberg, some of you may know, who's recently retired, but they have a history of working on issues around CAFOs, and including involvement with groups up in around Grinnell who are trying to sort of get some more, I guess it should be legislation or policies around just investigating the health impacts. So we were involved in a study there around smells and odors, as well as other aspects of that. So what we've been doing lately is trying to, I think there's a network of folks who are trying to really, in communities that are affected by CAFOs, to sort of work with them and make sure that the research that we have, the knowledge that we have, can be deployed to them as they're meeting with legislators, et cetera.
Sorry. Does CBPR include meetings with families of those dying from gun violence?
Another great question. We have a researcher, Corey Pigeza, who's been very interested and actively engaged with some of the folks in Cedar Rapids around trying to do reduction of gun violence. It is an interesting question because a lot of our funding, including for our Injury Prevention Research Center, comes from CDC. As you know, there's been a ban on ability to even, I think, say the word, but certainly around funding for that, so that has been a challenge. But some of our partners at other schools of public health are beginning to help galvanize public health schools to really begin to be more active in this area. I think they always have, but to try to think about how we could get more funding to sort of push back on those issues and investigate them more, particularly interventions to reduce gun violence.
Question is, where you have identified desirable policies, how, if at all, does the College of Public Health participate in the effort for legislative action?
Several. One is that we, which is an advantage, I think, of CBPR, if you are receiving federal funds for a research grant, you cannot, quote, lobby. You can educate. And we do a lot of educating. So, but you also, where partners, your community partners, can do what they want because they are not affiliated with an institution. So that can be very helpful when you're kind of, don't want to cross the line that your funders are concerned about. The other thing that we have done is, for example, again, in the area of environmental health, started more than a few years ago. Again, it was David Osterberg and Peter Thorne and others at the Environmental Health Sciences Research Center doing state legislative workshops. And so there have been several that have been done here in Iowa. It's a model now that people have taken from us and are doing. We helped to introduce one in Michigan around water after the Flint water crisis. But actually, we were talking about all the other water issues beyond that one, some that are in this state in terms of nitrates in the water, et cetera. And so that is one way where, a lot of actions are at the state level. We tend to think federally, but if you can begin to educate policymakers about environmental health and the real concerns there, then hopefully you can get some changes done.
One, anti-vaccination, quarantine, do these terms belong together? And what would be the impact of CBPR?
We did have a speaker at the college the other day, the author, the pediatrician from Flint, who was the one who discovered the lead poisoning in the kids and has written a really compelling book. And she said, we live in this age where people tend to want to ignore evidence in front of them, and those were the two she talked about: climate change and vaccines. So, I have to scratch my head because I think the evidence is there. It's solid that vaccinations do not cause autism. That study that started it all has been discredited. And yet, the people seem to be seizing upon that. Some for a belief, I think, more of individual rights and what you can and cannot do, versus, whether or not the health impacts of it. So I don't know that we know the answer. I think we keep plugging away at least at persuasive communications, and how can you craft that message, and what we in public health can do a better job, because sometimes we probably don't do as good as we can of sharing what we do know in a way that is compelling. So.
I'm going to combine a couple, and I figured out the first question I was trying to read, which is, the first question is, I'd like to hear more about your partnerships in Kenya and other African partnerships. And then the other one was about a question about the involvement in Haiti, what involvement there is, as Chris Burrish is going to be presenting to us soon. So.
Let me take Haiti first. We've had students who've worked closely with Chris and done practicums there, and it's been a great experience. We also have a faculty member, Jeff Dawson, who's our Associate Dean for Faculty Affairs, who has a long-standing commitment and relationships in Haiti. He goes every year. He's a statistician, and he actually lends his skill to hospitals and healthcare centers around collection of data. And is, I think, keeps threatening that he might take a student group with him, which we'd be excited, because sometimes you can't get biostatisticians to pursue international travel, so this would be a win-win for us. Let's see, and the other one?
Kenya and other African.
Oh, yes. So the projects in Kenya, Kelly Baker, I mentioned water and sanitation and health, and she actually does fascinating work on this issue, open defecation. So in some countries, India being one of them, some they're just not latrines. And so people have to go out into the open. But others, such as in India, it becomes, particularly for women, more of a cultural phenomenon, in the sense that in some places it's not safe to go by yourself. So women will go out and have a defecation, circle. I don't know how to call it. And Kelly actually could explain this more. But what she's also very interested in is sort of exposures from others, like where, in some cultures it might be fine for kids to defecate on the ground. Well, how much does that then impact the public health, and how much could that spread and things like that? So she's involved in that in India, but also in Kisumu in Western Kenya, and has done some really novel development of new techniques for measurement around the water and sanitation and health. And then Will Story, who I mentioned, has been working on some issues, again, I think, around maternal and child health with the university in Kenya. We're also in the very start of trying to establish a partnership in Togo in West Africa. And their interest areas are, surprise, surprise, environmental health. There is an NGO there that's working very much with a village that is next to a sacred forest. And they're very concerned about the effects of potential tourism in the sacred forest, but also environmental exposures. What is it? There's a cement factory and some other factories upstream. So how much is water being impacted? So we're working right now. I think I have a meeting next week with a student in Peter Thorne, and also Gideon Zamba, who is a biostatistics faculty member and from Togo, on how we can get a student over to do that sampling. So
when you mentioned being respectful of other cultures while in that country, what strategies do you employ to avoid going into another country as Westerners who will fix a community in a week? And then also, are your projects able to stay away from students performing tasks on or with local residents that the students would not be able to do if in the U.S.?
Yes, yeah. I think that last one is huge. I think there are stories out there of particularly clinicians or medical students who will go to another country and then be able to do medical procedures they would never be able to do at home. So we've done, and I don't know if you want to speak to, Sophie, some of the things you've done around training and vetting of processes.
Yeah, so
You need
microphone.
come up to the microphone. Thank you. Sure.
So we do offer our own internal pre-departure orientation for any student who goes abroad, regardless of where they go, and we do tailor that to their experiences. But one of the reasons we've chosen the partners that we've chosen is because Child Family Health International in particular has been at the forefront of really setting the standard for global health ethics. They originally started sending medical students abroad, which of course is a big issue, and have now moved into public health. But they have a very comprehensive multi-month pre-departure orientation that goes through things like cultural sensitivity, kind of how to extract yourself from a situation in which you might feel uncomfortable, like you cannot get away from something that might be unethical. So that's really, it depends on the student experience and what they're intended to do, but we really do impress upon our students that they are not medical students and you do not perform any sort of procedure that you wouldn't be qualified to do here in the U.S.
Oh, good.
So, good. Okay. So at this time, then, we conclude our program, and I want to give a big thanks to Edith Parker for her presentation. Thank you. And also the assistance from the last question. I also want to thank our sponsors, the University of Iowa's International Programs, the University of Iowa's Honors Program, the University of Iowa Public Policy Center, and the Stanley U of I Foundation Support Organization for their generous support. And we also thank today's special sponsors, Christopher Squire, Conrad Schultz, and Mason K. Braverman. And we thank City Channel 4 for making our programs available for the viewing audience. Now, Edith, I have, as a small token of our appreciation, we want to present you with the very coveted Iowa City Foreign Relations Council mug.
That is awesome.
That's great. Great.